Thank you, Grigory, for the invitation. And I think this is one of the exciting topics in cardiovascular surgery, one of the fields that is kind of still in development, so to speak. And in our understanding of the disease, all the type B dissections are complicated because even when you get away with medical therapy, you haven't fixed the problem. It's not an infrequent problem either. 3 per 100,000 persons per year, which brings 9,000 new cases in the United States. 25% are only treated with TVAR. The rest is medical therapy. Acute complicated type B dissections, mortality rates are up to 50%. There are many studies that have shown decreased in hospital morbidity and mortality with TVAR. So that's the known part. That's what we kind of do as a standard of care. Uncomplicated or chronic dissections, traditionally treated with optimal medical management. Again, as I mentioned earlier, aneurysmal degeneration or rupture happens in 20 to 50% of the time. So medical therapy is not the answer. We use guidance in our strategy looking at the false lumen. That's the first thing that everybody's been taught to kind of look at in making decisions. Chronically patent false lumen is independent risk factor for aneurysmal degeneration and dilatation, dissection-related rupture and death. On the other hand, false lumen thrombosis predicts better long-term prognosis. Goals of the endovascular stent graft placement: number one, cover the proximal tear, re-expand the true lumen, and potentially lead to false lumen thrombosis. Unfortunately, we're unable to predict false lumen thrombosis after TVAR as of yet. So medical therapy, these are retrospective review of patients, different studies, and shows that the mortality is actually quite high at 30%, at 30 days, and definitely 1, 3, 5, and 10 years. It ends up being 50 to 70% mortality. The first reports of non-surgical reconstruction of the thoracic aorta done by Dr. Nienaber and at the same time Dr. Dake showed that endovascular treatment of acute and subacute dissections is possible and needs to be explored. Survival for complicated acute dissection following TVAR. This study was published in the Annals of Thoracic Surgery 2008, looking at a total of 942 patients with complicated type B dissection treated with TVAR, and you can see the survival rate is about 88%, and the follow-up is 20 months. So not bad. That's why we tend to fix with TVAR most of the complicated type B dissections. And that's one case of one such case. You can see at the level of the visceral segment how small the true lumen is, and when you look with IVUS, you have also an element of dynamic collapse of the true lumen, which makes actually things worse than what you see on the CT scan. Proximal aortic diameter here, normal caliber, 25, 29 millimeters. At length of proximal landing zone, about 4 centimeters. And with dissection, we kind of tend to not oversize, usually try to match the aortic diameter. Unfortunately, the devices that we're using, which are Gore and Medtronic, we almost never use Cook. But either way, these devices are designed for treating aneurysmal disease, and they have a lot of radial force. So when you use such device with dissection, you have to be very careful because you're kind of trying to align the layers of the aorta. You're not trying to fix the device will stay there. So that's something that the technology should think about and kind of develop devices accordingly. We use IVUS exclusively. First of all, you have to know that you're in the true lumen, number one, and also it guides you with your sizing, although we usually try to match the size of the aorta. And in this particular case, you can see the true lumen is quite small. And this is the same case, 30-day follow-up, shows complete exclusion of the proximal fenestration. Unfortunately, we have a distal retrograde fenestration, which probably developed at the time of device deployment, which basically led to tear. But bringing the problem from proximal to distal makes it much easier to fix later on. And we can see that the false lumen is almost completely thrombosed. And the speaker after that will kind of talk about fixing chronic problems, but this is something that we fix routinely, sometimes at the time of the procedure, sometimes later, which will be basically visceral debranching, snorkels, sandwiches, and fenestrations. Okay, so that's another common scenario. This is actually a commercial pilot, young guy with hypertension, otherwise completely healthy. You can see the poor nephrogram on the CT scan, so type B dissection with renal malperfusion. Again, IVUS to make sure that we're positioning our device in the true lumen. And we use limited contrast. We have done cases just by IVUS guidance, but we do use contrast sometimes. And here you can't see very well, but we usually, after we deploy the first piece, we do interrogation with IVUS, and we see if there is a need for another piece. And quite often we go as low as the visceral segment. We do complete repair down to the celiac artery, and the paralysis is insignificant, actually. Again, with IVUS and angiography, you can see the dissected left renal artery, positioning a stent, and on the left-hand side, poor nephrogram on the angiography, the torn artery. On the right-hand side, you can see excellent perfusion of the left kidney, and what we try to do in these acute settings is just put a stent that barely gets to the true lumen, maybe 1 to 2 millimeters, and have very good success with that. So complicated dissections treated with endografts do as well as uncomplicated dissections managed medically. That's a known fact from the IRAD registry. Looking at our experience with complicated dissections in acute settings, you can see on the right-hand side that the medical therapy doesn't change anything. On the left-hand side, you can see positive remodeling, true lumen increase and false lumen shrinkage. Also, what we noticed retrospectively is that the false lumen thrombosis with TEVAR on the average is about 60 to 70%. Another volumetric analysis of type B aortic dissections treated with TEVAR, increasing aortic diameter preoperatively increases the risk of TEVAR failure. So we tend to fix these early on. In acute, subacute, or chronic settings, the earlier you fix it, the better chance you have for aortic remodeling. Long-term results of the INSTEAD trial, and these are actually the first 2 years, didn't show any difference between TEVAR and optimal medical therapy versus optimal medical therapy. Again, we have to use some guidance as to which patients need to be fixed, and that's a very nice observation showing the size of the proximal thoracic aorta and the patency of the false lumen. Obviously, patients that have smaller thoracic aorta and patent and closed false lumen do better than the patients that have larger thoracic aorta and patent lumen. Another predictor for aneurysmal expansion is the size of the false lumen at the level of the proximal thoracic aorta. And Song and colleagues show that if the size is less than 22 millimeters, the aorta does not really change significantly on follow-up, and you can see this on the left-handed slides. On the right-handed side slides, you see a false lumen that is greater than 22 millimeters, in this case 27 millimeters, which leads to aneurysmal degeneration. So that's another guiding parameter that you can use in your decision making. Again, aortic remodeling was actually shown with the INSTEAD trial, increase in the true lumen and shrinkage of the false lumen at 3 months, 1 year, and 2 years. Now we have the results, the INSTEAD XL results, which basically shows the 5-year follow-up. Primary endpoint, all-cause mortality at 5 years, and secondary endpoints, aortospecific mortality and disease progression. Key results. The treatment goals to cover the entry tear, to stabilize the aortic diameter, to confirm complete false lumen thrombosis, and in the end, positive aortic remodeling. And you can see that positive aortic remodeling, which will be sealed entry, thrombosed false lumen, shrinking false lumen, which is obviously enlargement of the true lumen, and absence of diameter progression was achieved in 80% of the TVAR plus optimal medical therapy versus only 10% in the medical management group. And you have about 12% absolute risk reduction in aortospecific mortality, also about 20% absolute risk reduction in disease progression. So the conclusions, obviously we treat the complicated type Bs with TVAR preferentially. Unfortunately, 70% of the type B aortic dissections are uncomplicated. And if we treat this with just medical therapy, we have about 30% 5-year mortality rate, and that's mortality. You have other complications, difficult to control blood pressure, renal failure, and so forth. INSTEAD XL demonstrates that elective TVAR results in favorable aortic remodeling and long-term survival. Reinterventions were a fact, but they were clustered mainly in the first year. TVAR prevents late expansion and malperfusion and encourages aortic remodeling. And also it's associated with improved 5-year aortic specific survival and delayed aortic disease progression. So the trends, especially in our practice, at this point are to basically try to fix all the type Bs, including the uncomplicated. And at this point in time in the States, we have 2 FDA-approved devices, the Gore and the Valiant device are approved for Medtronic, are approved for treating dissection. And they didn't really specify if it's complicated or uncomplicated. Technically, they're approved for treating uncomplicated dissections. And that's actually, we believe, the right time when you have to intervene, because that's when you have the best chance to remodel the aortic wall and basically help the patient long term. Thank you.